Hey everyone, and welcome back to the Deep Dive.
Great to be here.
We're really digging into some crucial stuff today from your Lewis's medical surgical nursing textbook, specifically problems of oxygenation, ventilation.
Yeah, this unit is foundational, right?
Absolutely. Our mission today is, well, to cut through the complexity of this whole section. We want to extract the most important nuggets of knowledge.
Yeah.
Give you a shortcut to being truly well-informed for your classes, your clinicals.
And the NCLEX, definitely.
And the NCLEX, yes.
Yeah.
We're going to try and connect the dots between the underlying patho, the assessment strategies, priority interventions, and, all those crucial patient care considerations.
Exactly. We want to build an integrative understanding, sort of highlighting patterns across different conditions.
Right.
And really emphasize critical thinking, the nursing process, and that collaborative care piece that's just so central to modern nursing.
Think of this deep dive as your essential guide, not just understanding what happens, but really why it matters.
And how you, as the nurse, can make a real difference. Spotting those subtle cues.
Okay, so let's unpack this. Let's start with the very foundation. The respiratory system itself.
Can't get far without it.
Its primary purpose, obviously, gas exchange. Getting O2 in, CO2 out, and we usually divide it neatly, right? Upper respiratory tract.
Your nose, mouth, pharynx, epiglottis, larynx, trachea.
Exactly. And then the lower respiratory tract.
That's the main stem, bronchi, bronchioles, and then down to the alveoli.
And remember those turbinates in the nose. They seem small, but they're actually crucial.
Oh, yeah. Warming and moistening the air. It's a vital first step. Really sets the stage for good gas exchange later on.
Vital.
And, to really appreciate the system, we need to zoom in a bit on the pulmonary functional unit.
Right, where the action happens.
That's where the magic of gas exchange truly happens, yeah. Involves the respiratory bronchioles, alveolar ducts, and the alveoli themselves. And it's also important, I think, to differentiate the two blood supplies. You've got the bronchial circulation.
Which feeds the lung tissue itself.
Exactly, nourishes the tissues. And then the pulmonary circulation, which is purely for gas exchange. That's a distinction people sometimes miss.
Good point. Okay, let's talk structure for a sec. The chest wall, 24 ribs, sternum, it's like this protective cage. Inside, the mediastinum separates the lungs. And then you have the pleura.
Right, the visceral pleura right on the lungs, and the parietal pleura lining the chest cavity.
And here's a really interesting clinical point.
Yeah.
The visceral pleura, the one on the lung, no cane fibers.
Right.
But the parietal pleura, lining the chest wall, it does.
Which is why pleurisy hurts so much.
Exactly, that inflammation hits the parietal layer. So a patient might say their lung hurts, but they point to their ribs. Understanding that anatomy helps you figure out their pain.
That's a perfect clinical nugget, and it connects right into understanding lung mechanics.
Okay, mechanics.
We're looking at compliance. That's the lung's ability to expand, essentially their stretchiness.
Like a balloon.
Kind of. Think of a brand new balloon. It's tough to inflate initially, right?
Yeah.
That's like decreased compliance. The lungs are stiff. You see that with pulmonary edema, fluid, or inflammation like in ARDS or pneumonia or even fibrosis.
Makes sense.
Now think of a really old, overstretched balloon. Inflates super easily.
But it doesn't snap back.
Exactly. No recoil.
Yeah.
That's increased compliance, like we often see in COPD where the lung tissue has lost its elasticity.
So different problems, but both affect breathing efficiency.
Precisely. And then there's airway resistance, which is just what it sounds like, the force impacting airflow.
The body's got defenses too, though, right?
Yeah.
Amazing was.
Oh, absolutely. The mucociliary clearance system, the mucociliary escalator.
Always love that name.
It's great, isn't it? It constantly secretes mucus to trap particles, and the cilia sweep it up and out.
But what about really tiny stuff?
Well, below the bronchioles where there aren't cilia, alveolar macrophages take over. They're the primary defense down there.
Like little Pac-Man gobbling things up.
Pretty much. They phagocytize foreign particles, bacteria. But here's the clinical link cigarette smoke. It really hammers those macrophages, impairs their activity.
Which explains the increased risk for lung disease in smokers.
Directly. And we absolutely have to talk about gerontologic considerations.
Yes. Huge implications for nursing care.
As we age, things change structurally. Costal cartilages calcify, so the chest doesn't expand as easily. Spine curvature can increase.
Leading to that sort of barrel chest look sometimes.
And respiratory muscle strength declines. Inside the lungs, the alveoli lose elasticity. Small airways might close earlier.
Yeah.
It all adds up to less efficient gas exchange, less tolerance for exertion.
And their defenses weaken too.
Yeah, that's a critical point. Immune function decreases, macrophages are less effective, cough is weaker, cilia don't work as well, mucous membranes are drier.
So higher risk for infections, aspiration.
Exactly. And it often means older adults don't show up with those classic textbook symptoms. They might just be confused or a bit lethargic.
Which makes our assessment skills even more critical.
Absolutely. We need to look for those subtle cues.
Okay, that's a perfect pivot. We've laid the groundwork on how it works. Now, how do we as nurses figure out if it's working well or if someone's struggling? Let's dive into assessment, starting with subjective data, what the patient tells us.
Crucial first step.
Thinking about Gordon's functional health patterns helps here, like health perception, health management. Always ask about immunizations, flu, COVID, pneumococcal.
Definitely. And how they use their equipment inhalers, home O2.
Oh, the inhaler technique. Huge issue.
So many patients don't use them right. You have to ask them to show you. It's not enough to just ask if they use it.
Good point. What about other patterns?
Well, think about activity exercise. We need to quantify dyspnea, right? Not just, are you short of breath?
Use a scale.
Yeah, like the modified Borg scale. 0 is nothing at all. 10 is so severe you have to stop. It gives you a number, helps track changes.
Right.
And ask if position makes a difference. That classic tripod position you see in COPD. Leaning forward, that's a clue.
What about sleep?
Ugh. Sleep rest. Ask about waking up at night. Is it chest tightness? Wheezing? Coughing? Could be asthma or COPD. Waking up needing to sit up orthopnea could be heart failure. Snoring, daytime sleepiness, maybe sleep apnea. Night sweats. Could be TB.
See, it's amazing how these non-respiratory questions give you the whole picture.
They provide that holistic context we need. Respiratory problems don't exist in a vacuum.
Okay, moving to objective data. What we see, feel, hear, the physical assessment.
Right. Inspection first. Look for signs of distress, fast breathing, using accessory muscle.
Like in the neck and shoulders?
Exactly. Look at chest shape. Normal AP diameter is about 1.2. Is it barrel-chested? Symmetrical movement? Any spinal issues?
Then palpation.
Check your tracheal position should be midline. If it's deviated, that's serious. Could be a tension pneumothorax, atelectasis. Chest expansion symmetry at the diaphragm should move about an inch, equally.
And percussion. Tapping on the chest.
Yeah. Normal lungs give you resonance, that low-pitched sound. If you hear dullness, like a thud, that suggests density, maybe pneumonia, fluid like an effusion.
What about the opposite? A booming sound.
That's hyperresonance. It indicates hyperinflation, too much air. You might hear that in COPD or a pneumothorax or even asthma sometimes.
Okay, and finally, auscultation. Listening.
Gotta know your normal sounds first. Bronchial over the trachea, loud, high-pitched. Bronchovesicular over the main bronchi, medium pitch, and vesicular over most of the lung field, soft, low pitch, like rustling leaves.
And then the abnormal adventitious sounds.
Right. Coarse crackles, think air bubbling through fluid or secretions, like blowing through a straw in water. Wheezes, that musical sound from air squeezing through narrowed airways. Stridor, a high-pitched sound, usually on inspiration, points to an upper airway obstruction, emergency. And a pleural friction rub.
Like leather rubbing together.
Exactly. Inflamed pleural layers rubbing. So here's a quick critical thinking challenge, maybe NCLEX style. You percuss hyperresonance and you auscultate absent breath sounds over one area. What's your priority? What are you thinking?
Uh-oh. Absent sounds plus hyperresonance. Sounds like air where it shouldn't be, and the lung isn't inflating there. Pneumothorax.
Bingo. That pattern screams pneumothorax. Air in the pleural space, lung collapsed. Medical emergency. Recognizing those patterns is crucial, putting the pieces together fast.
Absolutely. Pattern recognition is vital. Okay, beyond our hands-on assessment, there are the diagnostic studies.
The tools that give us more info.
Pulse oximetry to sputum. Quick, easy, non-invasive check of saturation.
Good starting point, but not the whole story.
Right. For the gold standard, you need arterial blood gases, ABGs.
Gives you the real numbers for oxygenation, PaO2, SO2, and that critical acid-base balance, pH, PaFiO2, HCO3. You have to know those normal values.
Non-negotiable. And imaging.
Chest X-ray is usually the first stop. Shows masses, infiltrates like pneumonia, consolidation, collapse.
What if there's fluid around the lung? Pleural effusion.
Then maybe a thoracentesis. We can stick a needle in to drain the fluid, either for diagnosis or just to relieve pressure.
Positioning is key there, right?
Yeah, absolutely. Patient sits upright, leans forward over a table, elbows supported, and afterwards. Monitor closely for complications, especially pneumothorax, and encourage deep breathing.
Got it. Okay, let's shift gears to interventions. How do we help?
Foundational stuff first. Breathing exercises.
Like pursed lip breathing.
Exactly. Pursed lip breathing, PLB, is simple, super effective, and easy to teach.
How do you explain it?
You tell them. Breathe in slowly through your nose for maybe 2 counts. Then pucker your lips like you're going to whistle or blow out a candle, and breathe out slowly through your mouth for 4 counts or longer.
So prolonging the exhale.
Yes, it prevents the small airways from collapsing, slows the breathing rate, and gives them a sense of control when they feel short of breath. It's like it gently splints the airways open on exhalation.
That makes sense. What about getting secretions out?
Airway clearance techniques, ACTs. Vital for patients with retained mucus. One simple one is huff coughing.
How does that work?
You teach them. Take a slow, deep breath in. Hold it for maybe 2-3 seconds. Then force the air out quickly with your mouth slightly open, like you're trying to fog up a mirror. Make a huff sound. Do that once or twice, then follow with a regular cough.
So it moves secretions up from deeper down.
Precisely. Moves it from smaller to larger airways so they can cough it out. There are also devices like the Flutter mucus clearance device.
The little pipe thing.
Yeah, it has a steel ball inside that vibrates as they exhale through it. Those vibrations travel down the airways, loosening mucus.
Cool. All right, let's talk about more advanced things. Artificial airway management.
Okay. Sometimes needed long-term, like with a tracheostomy.
Right, for prolonged ventilation. What's key for nurses there?
Cuff management is huge. That little balloon on the end needs the right amount of air. Too little, and air leaks around it, compromising ventilation. Too much.
You can damage the trachea.
Exactly. Risk of mucosal damage, necrosis even. We use the minimal occluding volume, or MOV technique. Listen with a stethoscope over the neck while slowly inflating a cuff until you just don't hear an air leak at peak inspiration. Then check the pressure on it between 20 and 30 centimeter H2O.
Okay. And suctioning.
Essential for keeping the airway clear. But you have to do it right. Always hyperoxygenate before and after. Limit each suction pass to no more than 10 seconds. Monitor their heart rate and O2 sat closely.
Complications like hypoxemia or dysrhythmias can happen fast.
They can. And don't forget oral care. Regular oral care, often with chlorhexidine, is absolutely vital for preventing ventilator-associated pneumonia, VAP.
VAP prevention, huge nursing role. Okay, what about chest tubes? See those a lot in critical care and post-op?
Right. Used to drain air or fluid from the pleural space, lets the lung re-expand.
What are our main jobs when caring for a patient with one?
Maintain the system integrity, all connections tight, keep the drainage unit below the level of the chest, and watch the water seal chamber.
For titling.
Yes. Titling that normal rise and fall of water with breathing tells you the system is patent and reflecting pleural pressure changes.
What if it's bubbling continuously?
Continuous bubbling in the water seal chamber usually means an air leak somewhere in the system or from the patient. Needs investigating right away. Intermittent bubbling with pneumothorax is expected initially, though.
Okay. And the drainage?
Monitor the amount, color, consistency, big red flag. Notify the provider if drainage is suddenly bright red or exceeds about 100 millimils per hour after the first hour or so.
And we should never milk or strip the tubing, right?
Absolutely not.
Yeah.
Creates dangerously high negative pressure. Old practice, totally contraindicated now.
Got it. Let's quickly touch on some common conditions mentioned in the unit, like pneumonia.
Acute infection of the lung parenchyma. We worry about different types: community-acquired, hospital-acquired VAP, and those multi-drug-resistant organisms.
Patho involves atelectasis.
Yeah, areas of collapsed, airless alveoli. And consolidation, where the alveoli fill up with fluid and debris.
Classic symptoms are cough, fever, dyspnea.
But, and this is crucial, especially for gerontology, older or debilitated patients might not have those. They might just present with confusion, stupor, maybe hypothermia.
So you have to be thinking about it even without the classic signs.
Exactly. And prevention is key vaccination. Flu and pneumococcal. Huge nursing role in education there.
Okay. What about asthma?
A really diverse disease, characterized by reversible expiratory airflow limitation, bronchial hyperreactivity, lots of triggers.
Allergens, smoke, infections.
Right. And what's interesting is the two-phase response. An early phase right after exposure, then a late phase hours later with more inflammation.
And if that inflammation becomes chronic,
It can lead to airway remodeling, permanent changes, irreversible loss of lung function over time. That's why controller meds are so important.
management focuses on action plans, meds, trigger avoidance.
And proper inhaler technique again, making sure they use their controller and reliever meds correctly.
Okay, connecting that to COPD.
Chronic obstructive pulmonary disease. Progressive, mostly caused by smoking, though there's a genetic piece too. AAT deficiency.
Patho here is chronic inflammation, mucus, cilia not working well.
And emphysema, destruction of the alveoli, leads to air trapping, that VQ mismatch where ventilation and perfusion aren't lined up properly.
Diagnosis confirmed with spirometry.
Yep, specifically the FEV1-FEC ratio being less than 70%. And here's a critical point for COPD. Oxygen therapy is the only treatment proven to improve survival.
Wow, the only one.
Yeah. So managing their oxygen is key. Nursing care also involves breathing, retraining PLB, again, effective coughing, nutrition support.
High calorie, high protein, small frequent meals.
Usually, yeah, they burn a lot of calories just breathing.
Okay, now let's shift into the really critical stuff. Acute respiratory failure, ARF.
Right. And remember, ARF isn't a disease itself, it's a symptom. It means the lungs just can't maintain adequate gas exchange.
Inadequate oxygenation or ventilation or both.
Exactly. We classify it as hypoxemic low PO2 despite getting supplemental oxygen, or hypercapnic high PaCO2 with acidosis.
Where's some early signs? Can be subtle.
Very subtle sometimes. Maybe just a slight change in mental status, restlessness, maybe a bit tachycardic or tachypneic, but it can escalate fast.
To severe dyspnea.
Yeah, like that 2-word or 3-word dyspnea. They can only get out a couple of words before needing another breath, using accessory muscles.
So early recognition is key.
Absolutely. And supportive therapy positioning, mobilizing secretions, maybe bronchodilators or diuretics, depending on the cause.
And comfort, analgesia, sedation.
Vital. But always look for the underlying cause of restlessness first, right? Is it hypoxemia, pain, delirium? Don't just jump to sedation.
Good safety point.
Yeah.
Okay, the most severe form of ARF.
That would be ARDS, acute respiratory distress syndrome, diffuse lung injury, inflammation gone wild.
And it progresses in phases.
Yes. First, the injury or exudative phase. Capillaries leak, fluid floods the alveoli. This leads to VQ mismatch, shunting, and the hallmark sign, refractory hypoxemia.
Meaning their oxygen levels stay low even when you crank up the FiO2.
Exactly. The oxygen just can't get across that flooded alveolar capillary membrane. Then comes the reparative or proliferative phase. Inflammation continues, the lung tissue starts getting dense, fibrotic. Compliance drops even more.
Making ventilation harder.
Much harder. And some patients progress to the fibrotic phase where the lung gets remodeled with scar tissue. Lots of complications with ARDS, VAP, barotrauma from the ventilator.
Barotrauma meaning lung injury from pressure.
Right. High pressures needed to ventilate stiff lungs can cause damage. Also GI ulcers, blood clots.
So management is intensive, ICU level.
Definitely. Optimizing oxygen, mechanical ventilation, often with specific strategies like low tidal volumes and PEEP to keep alveoli open but minimize injury. And prone positioning.
Flipping the patient onto their stomach.
Yep. It sounds simple, but it can make a huge difference. Gravity helps shift fluid away from dependent lung regions, helps recruit collapsed alveoli in the back, and improves that VQ matching. Can really boost oxygenation.
Wow. Intense stuff. So we've really covered a lot, journeying through the whole oxygenation and ventilation world from this unit.
From basic anatomy right through to ARDS management.
We've seen how that detailed assessment, understanding the patho, and knowing those key nursing interventions all fit together.
They're completely integrated. And that's the challenge and the skill, isn't it, for you, the learner, to keep synthesizing all this information.
Recognizing those subtle changes.
Anticipating patient needs, even when the picture isn't totally clear yet, that's critical thinking in action.
That's exactly right. Whether you're helping someone with, a simple nosebleed procedure or managing a complex patient on a ventilator in the ICU.
Your ability to connect those dots, to see the patterns.
That's what turns knowledge into effective, life-saving, and compassionate care. Well, thank you so much for joining us on this deep dive today, and thanks to all of you for being part of our last-minute lecture team.
Yeah, absolutely. Just remember, the best nurses, they don't just do tasks. They connect the what to the why. They understand, they advocate. So keep asking questions. Keep learning.
And keep diving deep.